let's clear up any confusion between hormone replacement therapy and anabolic steroids. There's been a lot of comments, a lot of controversy, a lot of videos, a lot of talk about testosterone. What is physiologic levels of testosterone replacement therapy, and where do anabolic steroids and where does testosterone therapy kind of become a steroid-like cycle? So what I want to share with you in this video is a little bit more about that so you have better understandings and some of the downsides about doing steroids and even HRT. So let's first talk about the dosages, okay? Most people, they're doing physiologic levels of hormone replacement therapy, and I'm specifically referring to in this video testosterone. I know women can do biased and estrogen progesterone with a small amount of testosterone. This video is a little bit more geared towards men, but we'll talk about women. So HRT doses of testosterone average around 150 to 200 milligrams per week. So I'm just gonna put 150 milligrams, and this is testosterone per week. Now, some people, and I don't recommend this or don't advise this, will do, if they're on HRT, one injection every 14 days. Now, I don't recommend that if you're on HRT because the blood levels are gonna peak and then they're gonna go down and you're gonna feel like crap, okay? So you want even blood levels if you're on HRT, and 150 milligrams is actually a higher end of an HRT dose, okay? So because most males are gonna make between 7 and 15 milligrams of testosterone per day in their peak reproductive years, and that starts to decline over time. Okay. Now, where do doses of anabolic steroids start? Well, I would say anything above 200 milligrams per week, okay? Now, some people might be running an HRT dose of 250, say it's HRT, 250 milligrams per week. They're really that's more like an anabolic steroid cycle in a sense, and they might experience some of the associated complications and health challenges linked therein, such as increased hypertension, increased absorption of iron and thickened blood, hypercoagulable thick viscous blood, and challenges there. So if you're doing anything north of 200 milligrams, you might want to prophylactically donate blood. You might want to do blood work to see how that is impacting your liver health. The liver enzymes we talk all about in the blood work masterclass, and some of the blood viscosity parameters, because that's a challenge there. But what most people do when they're doing anabolic steroids is they will stack testosterone with 1 or 2 or 3 or sometimes 4 or 5 other drugs. That's where the challenges come in because you're adding orals here. Oftentimes people will add in oral agents, okay? So you might add in Dianabol, you might add in Anadrol, some people add in oral or injectable Winstrol. Because what happens is when you start taking either HRT or steroid levels of testosterone, is these things take about 14 to 21 days to increase blood levels because they are fat soluble, they break down over time. Depending upon the form of testosterone, whether it's a propionate, an ethionate, a cypionate, the propionate is going to break down faster and increase blood levels quicker. The downside there is the injections need to be more frequently, okay? So the challenge here is when people go on anabolic steroids, they're not just doing testosterone, they're often combining other drugs, and those other drugs have consequences, side effects. As I mentioned, the most common challenge with steroids is the blood viscosity and the hypertension and the issues therein. Over time, that can lead to coronary artery disease, a lowering of the ejection fraction of the heart. That can lead to also peripheral vascular disease and accelerate aging and hair loss as well, because we know that dihydrotestosterone can cause atrophy or shrinkage of the hair follicles. And so there's some challenges that are associated with this because heart disease is the #1 leading cause of mortality, and when you get into anabolic steroid cycles, you start to exacerbate and worsen the risk factors that are linked with heart disease. Again, blood viscosity, really important. We talk about that in the blood work masterclass. Now, what are some considerations for people who have low testosterone and might want to consider taking HRT? Well, it really depends on your age and whether or not you're comfortable with the fact that if you decide to go on HRT, particularly with injectable testosterone, whether it's a propionate, cypionate, ethionate, or whatever, what's going to happen is over time, your testicles are going to atrophy. This is common because essentially when your blood levels get to a certain point, your brain is no longer going to send the luteinizing hormone and follicle stimulating hormone to the testicles. They're going to atrophy. So you're at risk for infertility, for challenges if you want to have children. So if you're under the age of 45 and you don't yet have children, I don't advise going on HRT. I would first suggest maximizing your DHEA levels. And we've talked a lot about that in other videos. Dihydroepiandrosterone is an adrenal hormone, and it's a precursor to both estrogen and also testosterone. So make sure, even if you're 45, 50, 60 years old and you want to go on HRT, maximize DHEA first, because that can feed into testosterone and you may not need to take as much or even consider HRT. So that's important. But also recognize that if you have low T, and I'm a huge fan of people going on HRT if they have low testosterone and they have the symptoms of low testosterone. Some people have low T, but they feel good. They wake up with an erection. They don't have erection issues. They have a high sex drive. So just because you have low testosterone and you don't have symptoms, that doesn't mean you always need to hop on testosterone. I think a lot of people, they want to get on testosterone. They think, oh, my blood levels, are a little bit low, so I'm going to jump on it. But again, the downside with that is when you go on HRT long term, you're going to get atrophy of the testicles, and you might experience some erectile issues as well. And you're going to depend upon this potentially forever. So that's a major commitment, because we're talking cost. You become a pincushion, because I think to get stable blood levels, it's probably better to do subcutaneous injections 3 days a week as opposed to just one intramuscular injection. So there's all these things that you want to consider. Also, people on HRT have the same considerations with people that do steroids, meaning the blood viscosity, the iron overload, the increased risk factors for heart disease. If their blood levels increase to supraphysiologic levels, because of the conversion of estrogen or testosterone to estrogen by aromatase and increased water retention, right, and weight gain. So those are all factors to consider. But if you're like, look, I'm committed to HRT, I want to do this, but I don't want my testicles to atrophy, well, how can you go around that? Well, you can either take periodically or once a month, you can take what's called HCG, human chorionic gonadotropin hormone. Now, this can help to keep your hypothalamic pituitary adrenal gonad axis online and help to prevent testicular atrophy. But HCG is quite expensive. HCG is also administered via injection, via subcutaneously. So if you want to go on HRT, but you don't want your testicles to atrophy, you might want to work with a doctor who will work with you to take HCG. Another consideration before even going on HCG or testosterone is to look at Clomid. Now, Clomid, actually, it's used in people who have breast cancer. It's used mostly for women because it does block the estrogen receptor, but it has the ability to turn on LH and FSH. So Clomid has been used. These two things are often used together, especially for people who do 12 or 14-week steroid cycles and want to come off to kickstart the gonads. So HCG and Clomid can be used, but again, Clomid has some issues. Some people, it can cause vision changes, light sensitivity. It can cause irritated mood. It can do a lot of different things because men need estrogen as well. And essentially this is almost an estrogen blocker, and there's downsides there, but you could do 25 to 50 milligrams every day for a week and then go back down to 50 milligrams every other day. A lot of doctors are not, because it's an off-label recommendation when you're taking Clomid for a male. This is not how this drug was intended to be used. It's sort of like an off-label use of this. Not many doctors are comfortable working with people with Clomid, but there is studies showing that in hypogonadic men, Clomid alone can actually increase testosterone. But again, there are potential downsides: vision changes, mood changes, light sensitivity. So these are things to consider. But if you're doing HRT or steroids, I do recommend periodic breaks just to help to renormalize the body and prevent some of the erectile dysfunction that can happen. Now, some of the guys that I've worked with that are on HRT for a long time, they don't have any erectile issues, but some men just find that, hey, I don't have the sensitivity there, things don't work as well down there, even though I'm on HRT and doing everything right. And so that is one downside that I think is not often talked about, because initially when people go on HRT, they feel great. But 5, 10, 15 years down the road, there can be some changes there due to the testicular atrophy. So those are the considerations. But again, the main difference here between physiologic replacement of testosterone and anabolic steroids or a cycle is the dose. So when you get north of the 150 milligram a week to north of, say, 200 milligram, that's when it becomes not so much physiologic replacement to more of a steroid cycle, and you're gonna have potentially the health challenges that are associated with that, specifically referring to the cardiovascular and the coronary artery issues, the low ejection fraction, and potentially accelerated aging. So these are all just considerations that we should actually be aware of. And I'm not telling you what to do. I just think you should be knowledgeable about these things. If you're considering either HRT or steroids, check out the blood work masterclass. You should be aware of blood viscosity, iron overload, all the factors in the liver health, and some of the parameters linked with blood viscosity, because I can tell you I've worked with so many people who have done SARMs, steroids, periodic cycles, and their blood work looks like hell, and it's scary. And that's why we see oftentimes people that have abused steroids, they die suddenly in their 50s or 60s, mostly from cardiovascular related issues. And I want to help you prevent, obviously, that, and just be more knowledgeable about what your blood work is showing. But people on HRT can also have some of those same things, just not to the same degree. So we know testosterone is very helpful for maintaining muscle protein synthesis, bone mineral density, preventing depression, all of that. But when we get into the supraphysiologic ranges, my friends, that's where we start to see the challenges. So either case, optimize DHA first, really important. And then sleep is going to be secondarily really important as well, because if you're not sleeping, you're drinking alcohol, you're not resistance training, you're under eating protein, under eating calories, you're going to have low testosterone. I mean, that comes part and parcel with that when you're dieting chronically. And so make sure you got all the lifestyle stuff figured out first before you just jump into one of these different categories. But again, I just thought this video might be helpful so you have a better idea, better understanding about how to smooth out or even out those blood levels. We've done videos before about using the insulin syringes and doing subcutaneous injections. Let's just say you're going to do 150 milligrams of testosterone a week, or 100. You might break that down into 35 or 40 milligrams subcutaneously 3 days per week, Monday, Wednesday, Friday, instead of just one intramuscular injection on, say, Sunday or something where people do that. So hopefully you found this video helpful. I'll put links below to related videos and also to the blood work masterclass. If you did find this helpful, I'd appreciate it if you could share this video, leave a like button, and also leave a comment, and let me know what you think about HRT versus steroids, and if you've benefited from HRT, and if so, how. We'll catch you in a future video down the road. Bye now.